Our next speaker is Dr. Irl Hirsch, professor in diabetes treatment and teaching chair at the University of Washington School of Medicine, Seattle. Dr. Hirsch received his medical degree from the University of Missouri School of Medicine in 1984. He completed his residency training in internal medicine at the University of Miami in Miami, Florida, and Mount Sinai Hospital in Miami Beach, and a research fellowship at Washington University School of Medicine in St. Louis. From both a research and teaching point of view, Dr. Hirsch's career has focused on studying the best strategies for the use of insulin therapy in both type 1 and type 2 diabetes. More recently, he has become involved with artificial pancreas technology and better understanding on the limitations of diabetes biomarkers. With regards to patient care, most patients in his practice have type 1 diabetes or atypical forms of diabetes. Over the years, he has been a passionate advocate for patients, ensuring access and affordability for glucose monitoring technology in the past decade with insulin. Dr. Hirsch has authored more than 250 research papers, more than 60 editorials, including the New England Journal of Medicine, and numerous book chapters, in addition to six books for patients and physicians. And one last part of his bio, he was my camp counselor at diabetic camp in 1974. And do you remember the name of that camp, Earl?
That was Camp Lion's Den.
Great, yep. Very appropriate. So I like to introduce everybody, Dr. Irl Hirsch.
Thank you, Brian. And of course, that property we were on was from the Lions Club outside of St. Louis in a little city called Imperial, Missouri. I don't know if you remember that very well, Brian.
Yes, I do. I thought it was Potosi, but Potosi was Trout Lodge. Yeah,
that's right. But in '74, we were still at Lions Den.
Yeah.
Going to try to.
Go ahead. You could share.
Okay. Brian, can you see this?
Yes, sir.
Yeah, and the one thing that is sad is I can't interact with the audience like I really enjoy doing. In fact, I can't even see the chats now, so don't try chatting with me because I had to close everything down so I could see my own screen. But I appreciate you, and I'll look at the chats when we're done. But I appreciate you this invitation to talk about time and range and continuous glucose monitoring. It would be really interesting for me to see how many people in the audience where their loved ones, their family members were using CGM. By way of introduction, I will just mention that for the last few years, CGM, continuous glucose monitoring, is considered the standard of care by the American Diabetes Association for type 1 diabetes. It is also considered standard of care for type 2s who take multiple daily injections. And we are quickly moving to just basal insulin only for type 2s and even no insulin. Medicare, for example, covers it completely for type 1s or type 2s on multiple injections or pump therapy. So with that introduction, this happened to be an Dexcom download a patient sent to me a few years back. This was a month of CGM data, and it's kind of like, it's actually kind of funny the way it looks. But as it turns out, this is somebody who has a hemoglobin A1C of 6.8%. So this is what a 6.8% looks like on a CGM about 10 years ago. Now, the pandemic has made moving our CGM data to the cloud and reporting even more important, because CGM is really geared and suited for the explosion of remote diabetes monitoring and care. And certainly on the physician side, and I would say the patient side too, this became critically important when the pandemic started almost 2 years ago now. And so now we are pretty much all using CGM as part of connected care, and we have standardized CGM metrics and reporting, which is what Brian asked me to talk about. I will tell you that in our clinic, and that's not just me, this is our entire University of Washington clinic, we have 90 to 95% of our type 1s use CGM and about half of our type 2s. And the reason why our type 2 CGM use is as high as it is, there's several reasons, but the main reason is that the majority of our type 2s use insulin. And so now we have the ability to personalize and optimize diabetes care. This was an actual quote that came to me. He said to me, dude, it's not how I get my insulin, it's all about my CGM. And he was right. If we take away for a moment the closed loop systems we use in type 1 diabetes, the hybrid closed loop, the 670G from Medtronic or the 770G or the tandem control IQ, and you have somebody where the pump does not talk to the sensor, it's really interesting. This research study, it was 94 patients over 3 years. And what you can see on the top two lines is everyone started with an A1C in the low 8s. And whether they received injections or whether they received a pump, if they were doing finger sticks, their A1C stayed about the same. But by the same token, if they were on injections or pumps and they were on real-time CGM, now these again are type 1 patients, their A1Cs came to around 7% and they stayed around 7% with the CGM. I can't overemphasize enough what a huge change, almost revolutionary, this has been, in particular in people who take insulin. I don't want to rank what was more important, the CGM, or Brian remembers the days moving from urine to finger stick glucose testing, but this obviously has made things quite different for us. So downloading is an important component, and I think everybody needs to look at their data. I think if you are using a CGM and it was prescribed by your doctor, you need to have your doctor go over the data with you. But it's important and it's not always easy. From this cartoon, I'm never having kids. I hear they take 9 months to download. And downloading, it has gotten better. It certainly doesn't take 9 months, but hopefully we are now in an environment, and especially if your physician and their team is downloading many, many different technologies with the different CGMs and the pumps, this can be relatively seamless. And it is getting a lot better. And in the Q&A, I can tell you what we are doing at our clinic. So how do you dissect the CGM download? You're not a math major. You never did well, nor do you enjoy math, but you look at these apps on your phone and you get all of this information. What do you do with this information? So let's just talk about the definitions. The average or the mean, it's simply adding the numbers up and divided how many numbers there are being averaged. It's everybody pretty much understands the average. That's not hard. But what's the definition between a mean and a median? And this is actually interesting in CGM or finger stick glucose testing, because if you have a median, which is just the middle value of all the numbers, and it's very different than the mean, that means you have a huge amount of variability. It's maybe not the best way to look at variability, but ideally, the mean and the median should be about the same. The standard deviation is what we used to use to look at variability. And now we use a coefficient of variation, or CV. It's a variability statistic that has replaced standard deviation, especially for CGM. And it's been very interesting how this number has evolved and how we are seeing the variability numbers get much lower in type 1 patients, especially using automated insulin delivery. As a rule of thumb, we want to see people with a coefficient of variation under 33 with type 1 diabetes and much lower in type 2. If you're making a little bit of your own insulin, the variability will be lower. And we can talk more about that if there are questions. And then the very important value of the GMI, Glycemic Management Indicator. And this came up a few years ago. We used to call this estimated A1C, but the US Food and Drug Administration said you can't use A1C if you're calculating an estimated A1C from CGM data. And so my colleagues, Rich Bergenstahl and Roy Beck, wrote a paper from a large population of people on GMI. And you as patients need to know your GMI and know, does your GMI differ from your A1C that your doctor measured? The GMI is simply a metric that's calculated from a formula from a population of mean glucose data. We used to call this, and this used to occur on the downloads and on the apps, as estimated A1C. You're not going to see that anymore. You're going to see GMI. It's on most of the downloads, but not on all of the downloads and the apps. Now, if you have a download that doesn't have the GMI on it, it's not a big deal. You can go to this website, jaeb.org/GMI, jaeb.org/GMI. And what you do from your CGM data, you want to have at least 14 days of data after you go to the website, and you just put the average of your CGM data in here. You can't do this with finger sticks. This really has to be with CGM. And then you press the button calculate on the website, and then you get the GMI, or estimated A1C, which in this case is 7.4%. So this is important because I like to use this. I actually think this is a better metric to use than hemoglobin A1C, but we can't do it yet. But it's important because we found that so many people, their GMI does not match with their A1C. And I've been interested in this for decades. Why did the finger sticks 25, 30 years ago, or why does the CGM now not match with the A1C? Because I've been looking at these downloads and looking at these downloads, and I didn't understand it. Well, over time, we've gotten to learn a lot about it. We've learned that people with kidney disease are going to run low. People with liver disease are going to run low. We've learned that African Americans, as a rule of thumb, read a bit high. We think it has to do with how long those red cells stay in the blood. And we are now learning that other ethnicities may read high or low. And if you have something funny with your hemoglobin that doesn't bother you, that can change it. We know different anemias can either make it high or low. But what's the most interesting to me is that a lot of the discordance, why the A1C doesn't match the GMI, it has to do with something you inherit from your parents. And that is, how long does your red blood cell live in your blood? And that is something where there's nothing wrong with you. It's just, how long does your red cell live? So what we did was we took 641 patients using the Dexcom. These were all type 1 patients. And we measured their A1C. We measured their mean glucose on the CGM. And look at the display that for any hemoglobin A1C, you have this huge variation in what the mean glucose was with the CGM. And what we showed, and we published this earlier this year, is that only 11% of patients did the A1C exactly match the GMI. So what that means is that if you have an estimated A1C or GMI of 7.0, your measured A1C from the lab and the measured A1C from the lab and the GMI is only going to be the same 11% of the time. But what if the GMI or estimated A1C is 7%? I can tell you that half of our population in our regular diabetes clinic, half the population, the measured A1C is going to be half a point off. So that means if the estimated A1C is 7, the measured A1C is going to be more than 7.5 or less than 6.5. And by the same token, if the measured A1C is 7%, the GMI in 22% of the people is going to be greater than greater than 8% or less than 6%. So this is a huge problem. And not surprisingly, we always saw this low in our patients who had kidney disease, estimated GFR being a function of one's kidney function. The A1C just doesn't work there. We've known that for years, but we really described how poor the A1C is. Now think about this from a moment. From a patient's point of view, if you're 30 years old and you're thinking about getting pregnant, if you use the A1C to make that decision, is it safe to get pregnant? 50% of the time, you're going to be a half a point off, and 22% of the time, you're going to be 1% off. We're using the A1C to make a decision if we should add or subtract the drug in type 2 diabetes. Well, that may not make sense. Or we are now using A1C to pay doctors their incentive to get people's A1Cs low. Well, that doesn't make sense to me either. None of this makes sense. And that's why CGM is a better way to look at glucose control than A1C. Now, the time and range is our main metric that we want to look at, not A1C now. And it's not changeable by a provider, a patient, or even an app. And it's sort of like coming down with the 10 Commandments when Moses said, this is going to be the 10 Commandments, this is going to be the time and range. And I point this out because patients on their apps and on their computers at home can change their time and range, change the goalposts. And what I'm telling you is you can't do that because the time and range is going to stay the same. So we can compare everybody's time and range with each other. And this is the time and range. You can't change this. Well, you can change it on your app. I would ask you not to. The time and range is 70 to 180. Those are the goalposts. That's where we want to strive to get. The time below range for hypoglycemia is less than 70, or really bad time below range, less than 54. We call that severe hypoglycemia. And time above range is either above 180 or above 250. So in addition to A1C, or maybe even opposed to A1C, we can now compare studies to each other by comparing buckets. And patients can also be compared. And you can't really do that. I can't compare A1C between 2 or 3 patients because for any given glucose, the A1C will be different for that patient. I am more interested in looking at the glucose as opposed to looking at a downstream biomarker for the glucose. And I can tell you, I'm not alone in that thought, but we're not quite there yet when it comes to FDA and journals and some other things. But what's important to know is we can compare time and range to microvascular complications. This was the DCCT study. And what these investigators did was they went back to the DCCT because quarterly, all the patients in this study, 1,441 of them, did 7-day fingerstick glucose profiles. And if you do the math, it's about 250,000 fingerstick glucose tests. And you can see, looking at retinopathy in this very large study, if they had greater than 70% time and range with their finger sticks, they only had 5% progression of retinopathy. Whereas if they had less than 10% time and range, the retinopathy, the eye disease, was 58%. So we can compare this, as it turns out, both in type 1 and type 2 diabetes. And that is why I think we should be using time and range and CGM metrics and not A1C. These are the targets, the time and range target. For most people, we want to be greater than 70% time and range and less than 4% time below range. Now, every 1% is about 15 minutes. So what we're saying is the target for most people with type 1 and type 2 diabetes is to be less than an hour hypoglycemic and less than 1% of the time, less than 54 milligrams per deciliter. And this is what we want most people to be. Note that the primary endpoint for older high-risk patients, and I don't know how to define high risk. Actually, we're going to have more description, I think, on what's older and frail. But here the primary thing is to get the hypoglycemia less than 1%, and we're not as concerned about time and range. The target here is more than 50%. So this was an international consensus conference that I was part of a few years ago. Note that for most type 1 and type 2 patients, 70% time and range, less than 4% time below range. I'm going to tell you this was based off of a study with hybrid closed loop technology in type 1 diabetes. We do better than this now. Typically, I can see greater than 80% in a lot of our patients, less than 2% time below range. I actually think we can do that now. And I think a lot of this change over time. Again, the primary endpoint for the older, frail patient is less than 1% hypoglycemia. But in pregnancy, this is where we change the time and range goalposts. We change it to 63 to 140. We keep it at greater than 70% in pre-gestational type 1 patients. Again, less than 4% hypoglycemia. And the 63 to 140 is what we use both in type 1, type 2, and gestational patients who are pregnant. That's the only time you can change the time and range, not because you want your time and range 80 to 130. Okay, and there's been a lot of research I won't go through here. There's an identical study in type 2 diabetes, but note that on average with an A1C of 7, on average you have 70% time and range. But note the huge amount of variability, huge. I mean, here's a patient with an A1C of almost 10% with 40% time and range, and yet here's a patient with an A1C of 8%, also with 70% time and range. There are huge amounts of variability with this. Different ways to look at the data. You can look at statistical summaries, and this is available on most of the apps. You can look at the ambulatory glucose profile. You can look at the daily view. Everybody has their favorite on what's the best way to look at. I probably look at more than one way depending on the patient. This comes from a website, and you can actually see, this is with the Libre, how you can see the green for the time and range again, the red for the time below range, and you can also see the ambulatory glucose profile. And you can identify trouble spots just by looking at the picture. Note that the orange is the orange here is the median, or it's the median in this graph. This is from a Dexcom. The dark blue is 50% of the numbers are in the dark blue here, but more importantly, you can see where the lows occur and what to focus on. You can see where the highs occur, and you can also see where the variability is the greatest, in this case, after dinner. High variability. But the AGP can present differently, but it's actually the same. It is standardized, but it looks differently. I mean, this is, for example, what it looks like with an InPen and the Dexcom and the Medtronic CareLink and Tidepool, and we can go on and on and on. But it's really the same thing. You just need to be careful knowing that these lines may be different in terms of what percentage of the blood sugars are within each color. So Brian, I would like to conclude that A1C may be misleading, so be careful. Compare your own GMI with your measured A1C. And this is why for type 2 patients who don't take insulin, I want them to use a CGM at least one time so I know, can I trust their A1C or not? Because if I can't, I need to know that. Time and ranges are the important metric, but one requires the ambulatory glucose profile to best understand that person's individual glycemic fingerprint and how to assist with diabetes management. Time and range targets need to be individualized, especially for somebody who may be older with a life expectancy that may be shorter, and certainly dealing with different goalposts during pregnancy. So we have to make this simple and intuitive so all of us, patients and physicians, can understand the goals. Is this string theory? No, it's my lunch bolus. And with that, I want to just show you, this is our new hockey arena here in Seattle called the Climate Pledge Arena. And what's very cool is my building is, our new building is just about a 10-minute walk away. If anybody's in the neighborhood and want to come up, would be glad to show you all the things going on here in Seattle. It's a lot of fun right now. But with that, I will stop. And Brian, thank you again for the invitation.
Earl, don't disappear yet.
I'm not.
Okay. I just want to say how important to me my CGM is. I cannot imagine before us not having a CGM. If I'm in between changing sensors, and I just don't get a chance to put it on right away, I feel naked. It's like I can't live without that anymore.
Brian, I saw you naked when you were 11 years old, so hopefully things have gotten better.
Okay. Thank you, Earl. Thank you.